service to the people concerned. And we will work together, Neurological Society, Psychiatric Society, IMA, CGP, and all the bodies will work together for a better world, for a better world for the senior citizens, for the people who are demented, for the people who are having memory issues. Thank you very much for being allowed to me with you. Congratulations, best wishes. And I declare this meeting inaugurated. Thank you.
Thank you, Dr. Alfred V. Samuel, for your words and for inaugurating the session. Now I invite Dr. Leelam Abraham, Chairperson, IMA CGP, for her address. Over to you, Dr. Leelam Abraham, madam.
Respected President, Dr. Joy Manila, our chief guest, Dr. Alfred V. Samuel, famous neurologist, Dr. Matthew Abraham, eminent psychiatrist, Dr. Arun B. Nair, Dr. Joy M.A., President, Neurological Society, Thrissur, Secretary, Joint Secretary, and other secretaries of Neurological Society, Thrissur, and all the neurologists in Thrissur, Dr. Gilvas, and all other senior members, and also my dear friends. Today, IMA CGP, along with the Neurological Society Thrissur, is conducting a seminar on Alzheimer's disease and related disorders. Now, we have blessed by the presence of eminent personalities, well versed in the subject and also well known, not only in Kerala and also outside Kerala. They will enlighten our knowledge with their vast and great knowledge and also academic bonanza. This Alzheimer's disease is the cause of the Alzheimer's disease is a reduction in the amount of acetylcholine in the brain. Anyway, these eminent personalities, eminent scholars, they will discuss about these Alzheimer's causes and also the treatment and other grassroots problems. And thus, in this World Alzheimer's Days, we are grateful for getting these eminent personalities, well known in Kerala and also outside Kerala and also in all over India, for their kind presence and attending this conference. Thank you.
Thank you, Dr. Leelam Abraham, for your felicitation. Now I invite Dr. P.C. Gilvas, neurologist, an eminent and senior most neurologist of Thrissur, who is the HOD of Jubilee Mission Medical College of Thrissur, and the organizer of this program, for the introduction of today's faculties. Over to you, Dr. Gilvas.
Good evening to all of you. President of the IMA, Dr. Joy, President of the Thrissur Club, again Dr. Secretary of both the IMA and the Neuro Club of Thrissur, Dr. Alfred, our chief guest, our speakers, Dr. Matthew Abraham and Dr. Arun B. Nair. This is a huge honor to introduce two eminent personalities on this Zoom meeting today. Dr. Matthew Abraham has been involved with teaching and spreading the message of Alzheimer's in the state of Kerala, and I would say to the whole of India. It has not been just a topic of a talk for him. There's been a passion with him. And as you listen to him, you see this passion come out as he goes along. For those of you who do not know Dr. Matthew Abraham, he, as he earlier said, is a Puneite who did his basic MBBS and MD from Pune, and then moved over to Mumbai, where he did his DM, and then came to Grace Kochi over the last almost 40 plus years. He's been a great neurologist, a great friend, a great organizer, and above all, I must say, a great human being and a great person. You will know this by the end of his talk. Dr. Arun B. Abraham and Dr. Arun B. Nair is too well known across the state of Kerala. He is extremely well written, spoken. He's a TV personality. He has conducted over 2,000 TV shows across the land. And I think we know more about him than what we think. In short, we have two real passionate people on this topic. It's my great pleasure to introduce them. And without further ado, I'll hand it over to Dr. Matthew Abraham for the first session of this Zoom meeting. Over to you, Matthew.
Thank you, Percy. Am I audible?
Yeah, you are.
President of this meeting, Dr. Joy Manjila, Chief Guest, Dr. Alfred Samuel, my co-speaker, Professor Arun Nair, my dear friends, Percy Gilvas and Dr. Joy, Dr. Leelama, members and officials on the days for conducting this meeting. It's a pleasure to be here among old friends, as I recognize so many of you who have been great well-wishers of mine. As Percy mentioned, Alzheimer's and aging has been a passion with me for the last 25 years or so. And it became even closer home when we had to look after my father for the last 6 years till I lost him 3 months ago at the age of 103. He was bedridden for the last 6 years. He was dementing. And the real problems associated with looking after these patients came to touch me in a way that made it even more important to realize how empathetic we need to be as physicians to look after these patients. I wandered lonely as a cloud that floats on high o'er vales and hills, when all at once I saw a crowd, a host of golden daffodils, beside the lake between the trees, fluttering and dancing in the breeze. For those of you who have learnt this poem in school, it will bring back some pleasant memories. For those of us who are interested in literature and English poetry, it is an understanding at a different level altogether. And for me, when I quote this poem, it brings back a memory which remains so fresh 15 years after it happened. We had gone to Scotland and gone to William Wordsworth's grave, and there watched the daffodils as he would have seen them through his eyes. 10,000 saw I at a glance, tossing their head in sprightly dance. It is a joke in the family that I knelt down and started reciting from memory, Daffodils and the Solitary Reaper, and all the poems that evoke such memories of the old, of school. And I was crying when I did it. And Zina, my wife, asked me, I can understand you kneeling down and reciting the poems from memory, but why were you crying? And I said, if I have to explain that to you, there is no point explaining it. And that is what memories are all about. You relive past things. They add color to life. They add depth. They add emotion. And everything that you have lived through, good and bad, can be recalled at short notice. And you relive old fights and old triumphs You strengthen yourself from past experiences. And life without memories would be an insipid platter. Last evening, I was interacting with my student, Dr. Hannah, and she spoke to me about her grandfather who is in his mid-80s. He's got multiple comorbidities. He's going from crisis to crisis medically, and things don't look very good. And she told me that she saw him holding his wife's hand, her grandmother's hand, and just crying. And her grandmother asked him, "Why are you crying?" And he replied, "It is just the thought that we have to part." And so when you look at it from that point of view, what memories bring back is an emotional component which goes far beyond the quantifiable experience. And every time you relive the memory, you look at it from a different perspective. You understand it in a different dimension. And that is what makes it so beautiful and life so colorful. And what happens when you lose a memory? Once more, it was totally by chance. A dear friend of mine got in touch with me last night. We were schoolmates together, benchmates, the closest of friends, a friendship that goes back beyond 50 years. And his wife is going down with Alzheimer's dementia. We were in college together. Theirs was the first love in our group. So I know them for a very, very long time and very closely. He was driving when he spoke to me, and we spoke for after more than half an hour. And he was just telling me what was happening to her and the tragedy of a deteriorating personality and a deteriorating cognitive function. And he told me about behavioral changes that had come in, where she was not able to respond normally to any emotion. She seemed indifferent to most things that happened. And he was wondering whether it was an aggravation of a depression and whether any of the drugs were contributing to this in any deleterious way. And I had to unfortunately tell him that it was probably the beginning of an apathy, which probably was a step, one stage worse in the whole disease. And I know that if he had not been driving, he would have been crying, explaining what was happening at home. And I, as a friend, cried internally with him. That is what memories do, and the importance of memory. It is our greatest faculty that we have. It is a faculty that enables our very survival, our sustenance, because without a memory, which is good or bad, you would be redoing all your mistakes all over again. And life would be reduced to a moment by moment, incident by incident experience without having learned anything from the past. It ensures your survival, because if you had had your fingers burnt, physically or metaphorically, you would know that you should not be getting into that experience once more, because your survival itself would be at stake. And the important thing is that because you have that memory, you would avoid a danger that would cost you maybe your life. What then happens to memory? Aging is a process that begins when we are born and goes on relentlessly, irrevocably, till the moment we die. Our neurons grow with age and reach a certain level of balance, after which they start slowly deteriorating. These neurons never reach a point of deterioration where there will be a loss of function to the extent that you are socially or professionally embarrassed. How does this work? The brain is essentially a computer. So it gets inputs from various sensory modalities. It may be vision, it may be hearing, it is touch, it is balance. These are sent to specialized areas of the brain, where the information, incoming information is processed. And the basis of the processed information, you come to certain conclusions in the visual or in the auditory or in the touch areas. Then the brain is interconnecting these various areas of specialization, the visual cortex, the auditory cortex, the somatosensory cortex, by connecting fibers and association areas which integrate all these incoming modalities. And on the basis of these incoming modalities, the brain comes to a certain rational conclusion as to what is the most relevant action or word that needs to be spoken in a particular situation. The brain is being bombarded by millions of bits of information, and yet the brain knows how to screen this and prioritize the incoming information so that what is most important to the person as an individual at that moment of time is allowed to get in and be interpreted properly, while anything that is not so relevant at that stage is screened out. All this is done because of the connectivity of the neurons between themselves, which are both physical and by neurotransmitter chemicals. Now just imagine what happens, what would happen. Exactly what would happen in a computer if you had short circuits occurring in different parts of the computer. The connectivity and the transmission of information from one point to the other, and the processing of information within these association cortices would certainly be affected in a deleterious way. And therefore, the conclusions that these particular areas reach would be inappropriate for that occasion, as a result of which the final output would be garbage. Exactly what happens in a computer where you say garbage in and garbage out. The dementing process can affect these circuits both in the incoming as well as in the outgoing modalities. When it reaches a level where your professional and social faculties or capabilities are affected to the extent that they impinge on day-to-day living, and you do not remain independent in your activities of daily living, that is when you call it a stage of dementia. So dementia by definition is the loss of multiple islands of cognitive function to the extent that they reach a point where it affects your professional and social functioning and affects your ability to conduct yourself independently on a day-to-day basis. In most of these cases, it is irreversible and relentlessly progressive. And unfortunately, we have not yet achieved any breakthrough treatments which will reverse most of these processes. So what happens when a person with dementia comes to you? As a clinician, we have to address it at various levels. Dementia is something that is going to affect every one of us in some way. If not ourselves, it may be parents, it may be closer friends, it may be people we know, it may be grandparents. And as the population is growing older because of the availability of better and better health facilities, you're going to have an increasing aging population that makes us more prone to develop dementia. It has been statistically found that when a person lives to 60, there is a 5% chance that he is going to get demented. And for every 5 years of extra life, there is an additional 5% of loss. As a result of which, if you have the good fortune or the ill fortune to live till 80, there is a 20% chance that you will become demented. So the implication is that with a rising population, with a population that is growing older, with people who are living longer, we are going to have this becoming a tremendous social problem. The medical problem is only the tip of the iceberg, because as of now, we are not able to address the medical problem and reverse the process. But as a social problem, it becomes a huge burden on society and on government and on professionals like us, but most of all on the people who are looking after the patients. It's usually immediate relatives, a son or a daughter more often a daughter or a daughter-in-law. And it is only when we ourselves have gone through that experience, you realize the magnitude of the problem and the thankless nature of whatever you are doing. My father survived for 6 years only because of the great nursing and the care and the love that my wife gave him. I was only a supporting actor. But he was the most gentle soul that you could ever find. And there were so many of my school friends who called when he passed away, remembering him to be the most gentle person that they had met. And yet in the last 3 years, he had turned into a totally different person. He had become aggressive, he had become abusive, he had become almost obscene, he was inconsiderate. Every little quality that he never had before. He was a totally different person. And the helplessness and the thanklessness of having to look after him 24/7, knowing fully well that it is going to deteriorate by the day. I can only tell you that death came as a merciful end. And most of us who will be looking after these patients, who are involved with these patients, will come to realize that especially when the person who is suffering does not himself be aware of what is happening to him, and it is left to the caregivers to anticipate and do what is necessary, the burden becomes magnified manyfold. As doctors, we need to look at it from a different point of view. Essentially, a person will come to you, or his relative will be bringing this patient to you, and it will almost invariably be that he has a memory problem. The peculiarity about Alzheimer's is the fact that the memory problem is usually for recent events, while old memories are retained till the last. And paradoxically, this is a very, very paradoxical loss of memory. And very often it would be a relative who comes and tells you that his father is probably faking this whole thing because he can remember minute details from his childhood, but he can't seem to remember what he had for breakfast this morning. And for us as clinicians, that is the giveaway clue. So the loss of episodes, the loss of autobiographical events, and a progression of involvement is what happens in the initial stages of what is Alzheimer's. And as the pathology spreads forwards and laterally, new circuits are getting affected, and therefore newer and newer cognitive faculties are getting lost. You need not look at it as Alzheimer's, you need to look at it as dementia, which is an umbrella term for all the entities that might result in cognitive loss. And depending upon which circuits are initially involved and the progression of these circuits, the initial presentation and progression of the disease may vary. So you may have other faculties of cognitive islands which are involved, which may be language, the ability to understand spoken or written speech, and the ability to express yourself. A person who is a good speaker or a wonderful writer starts losing his ability to do what he excelled in at one time. And over a period of time, his speech becomes garbled and his understanding of speech becomes even less so. It may be in terms of behavior, because the mind is part of the brain and it forms circuits which are responsible for the way you behave in a particular situation. You may be a very cultured and sophisticated person, but those are the last circuits that are acquired in the process of evolution. But unfortunately, the first ones that are lost when there is a pathological process going. So a person who is a very subtle, lovely, humorous person suddenly becomes a different person altogether, like my father did. He may be aggressive, he may be dependent, he may be withdrawn, he may have mood swings, he may have wandering tendencies. You have the difficulty in visual spatial orientation. You do not know how to orient yourself in space and navigate in space, and so you tend to lose your way. You lose control over your micturition and bowels. And over a period of time, while this entire process of pathology unfolds, more and more faculties get affected, and the patient is finally reduced to a helpless, bedridden invalid, eventually succumbing to either infection or bed sores. The end is often merciful. As of now, we unfortunately do not have treatments. And therefore, the attitude towards this particular problem, while it is a huge social one, has been so far, or until very recently, nihilistic. But as public awareness of the problem increases, and people realize that this is not an aberration of a normal, natural aging process, but it is a pathology in its own right, we are beginning to get more and more people who come early enough so that hopefully some of these can be identified in time and you can have reversible treatments for them. As a doctor, the first thing that you need to know is, the first question that you need to address is it dementia? Because there are mimics. A person can have something that happens only once, or only one cognitive island or faculty may be involved, and that by definition is not yet dementia. It may be only mild and it would not have reached a level where his day-to-day activities are affected. It may be a dementia mimic, like pseudo-dementia, which is a presentation of depression or anxiety. So it is for us as clinicians to identify these and tease them out to identify what is genuinely dementia, or a process of ongoing and progressing dementia from something that is different or a dementia mimic. If you think that it is dementia, then the next thing that immediately comes to mind is it a treatable dementia? There are only a very small percentage of these patients who are demented which are treatable. For example, you have a tumor, a brain tumor, or you have normal pressure hydrocephalus, or a hypothyroid state, or you have a B12 deficiency, or you have small multiple strokes which are partially treatable if you address the risk factors. So the most important thing is to be able to identify the treatable diseases and to be able to identify them early enough. Because if you miss the diagnosis at that stage, what is an eminently treatable disease eventually becomes a totally untreatable one, and it mimics or goes on into an untreatable dementia. So we have the next stage which we need to look at, and that is it a partially treatable dementia? And that is what happens with multiple strokes, where you have risk factors like high blood pressure, diabetes, high cholesterol, lifestyle, obesity, and so on and so forth, which if properly addressed and treated in time, slows down the progress of aging or accelerated aging, or the chance of another stroke from happening. And some of these areas which are stroked out do recover. And so there is a partial improvement in these patients and will help improve their quality of life. Unfortunately, the treatable and the partially treatable ones do not constitute, they constitute only a small minority of these patients. And you're left, unfortunately, with a large basket of dementing patients who are in the irreversible or untreatable category. It may be Alzheimer's disease, which is the commonest, but it could be frontotemporal dementia and all its variants. It could be dementia with Lewy bodies. It could be early variants of Alzheimer's disease. Or it could be pathologies which go hand in hand, and the comorbidities aggravate the process of deterioration. Unfortunately, as we mentioned before, the treatments that are available are not adequate to reverse the process. There is some scientific evidence to think that some of these processes are slowed down with the treatments that are available. But slowing down is not good enough for the patient who's suffering, and even less so for the family. So when you, with your scientific scales, tell the patient that he looks better or he seems to be improving, for the patient's caregivers, it hardly makes a difference, because what you need to address for them is the patient less dependent on us that he was before with your treatment? Are his behavioral problems, which are the most aggravating aspects of dementia, less aggravating for the people who look after him? And in the process, is he becoming more independent than before? And the process is the quality of his life, and much more the quality and stress of the caregivers becoming better or less. If you can address these questions positively, then you can help with the patient. Unfortunately, because of poor awareness, unfortunately, because of negative attitudes and blocked mindsets, we in our own medical fraternity tend to still have a nihilistic attitude to this whole problem. But what we must always remember is that treatment of a patient and your duty as a physician does not only mean reversible treatment or treatment to cure. You as a physician are a family counselor, a family confidant, somebody whom the family comes to be expecting a shoulder to cry on, someone who can share sentiments and you are empathetic to it. And each one of these roles that you play as a physician and as a human being and an empathetic sharer of that person's grief and sorrow will help improve the state of mind and the quality of life for the caregiver. Because unfortunately, we are not addressing the real problems or the medical problems which the patient is himself going through. And therefore, we need to be that empathetic and we need to be that consoling and that we need to be that supportive of people who are going through this and families who are suffering. Because there, but for the grace of God, go I. It could be you or your family. And only when it touches you, you will realize how deep the suffering can be. So then we go back to what we need to do as professionals and what we need to do to spread awareness. Everything that we do to spread awareness, which helps people get over the feeling that it is because of something that they have done or not done, which makes them feel guilty because society points fingers to try to find reasons for why something is happening in a particular family. And the immediate relatives go a tremendous amount, first of denial. And once they understand that there is no coming back on this, they go through guilt and then they go through resignation. And when this becomes a day-to-day chore, where your mental, emotional, financial, and physical faculties are stretched to the limit and more, a day-to-day care sometimes becomes very mechanical. And all the empathy that the patient deserves and the support that the relatives need is lacking. And therefore, improving public awareness and increasing the knowledge and spread of what is happening in dementia to the public at large and to the focused education and upgradation of knowledge of the immediate faculty, of the immediate family members would go a long way to alleviating suffering, improving quality of life, and giving them a recharge which helps them sustain the quality of care. To be able to have societies which are supportive in terms of providing trained personnel like nursing assistants who are empathetic to what is happening. The biggest problem is to get people who are trained, because the ones who come cannot handle the behavioral problems and they run away and the family is left high and dry. So doing that as a medical fraternity is one of the most important things that we can do. And in the process, when you interact with your patient, when you become more empathetic, you become a better doctor and you become a better human being, and your own relationships with your patients and within your own family and members would only be enhanced by the experiences that you go through in taking care of these unfortunate patients. To be nihilistic about it is very sad. But may I remind you that there were many, many diseases for which we had no cure. I wonder how many of you know why smallpox is called the smallpox? Because there was a great pox, and the great pox was syphilis. And in the Middle Ages, syphilis was the greatest killer that ever was. It used to be spread by prostitutes who followed armies across Europe. And it was a killer in its own right. but one shot of penicillin, and today smallpox, syphilis is history. Before penicillin came, it used to be mercury. And the joke was one night with Venus and life with Mercury. The point is that we have something which was not at all treatable, and suddenly you have a magic cure. For those of you who are interested in history, if you look at pictures of the iron lungs and the children who were in them suffering from polio in the 1940s and 1950s in American hospitals, it is actually sad to look at them. And all the research that went into polio and finding out the polio vaccine really got a boost because Franklin Delano Roosevelt himself had polio. And then you had the breakthroughs of the SARS and the Sabine vaccine. And today, with the efforts of WHO, Rotary International, and many non-governmental organizations worldwide, polio will soon become a footnote in history. We mentioned smallpox. I still bear the vaccination marks of smallpox, but our children don't. And that is because smallpox has forever been eradicated. And there are only 2 samples that are left in the world of the smallpox virus, one in the United States and the other in Russia. And today, the only question that we are confronted is do we, as a member of the animal kingdom, have the ethical and moral right to destroy another species altogether? And this is true with many of the diseases. When we started as neurologists, first you will remember 35 or 40 years ago, neurology itself was a disease where you made fancy diagnoses, but no treatments available. Strokes used to be treated with aspirin and sitting on your butt. Today we have treatments available. We have interventions. Multiple sclerosis is a treatable entity today. HIV was a scourge 30 years ago. Today, it's a treatable disease. So all you need is really one serendipitous breakthrough, maybe in some other field, for a breakthrough in treatment of diseases which so far have remained untreatable. If we are lucky, this may happen in our own lifetime. May I end with just a continuation of what I started with. A memory that will bring pleasure when we relax and cozy up in something that we remember with great joy. Wordsworth once again. For oft when on my couch I lie, in vacant or in pensive mood, they flash upon that inward eye, which is the bliss of solitude. And then my heart with pleasure sings and dances with daffodils. I leave you with your memories, and I hope that you will remember and empathize and realize how precious these are for our very existence and much more for our quality of life. Thank you so very much.
Thank you, Matthew. That was a wonderful talk. And if you must know, you brought a tear to my eye as well. I now call upon Professor Arun B. Nair for his talk on a very important aspect of Alzheimer's disease. Over to you, Arun.
Thank you very much, sir. My sincere gratitude to the organizers, Thrissur Neurological Society, IMA CGP, for giving me this great opportunity to share the stage with a stalwart like Dr. Matthew Abraham. And my sincere gratitude to sir also for those kind words about me. So behavioral and psychological symptoms of dementia. It's a very important practical problem which is adversely affecting the physical and mental health of the caretakers of people with dementia as well. So let us start with a small description which is given by Alois Alzheimer, a description of the behavior of the first patient which he had described in 1906, the person known as Frau Geste, a 51-year-old lady. The description goes like this: one of the first disease symptoms of a 51-year-old woman was a strong feeling of jealousy towards her husband. Very soon, she started showing increasing memory impairment. She could not find her way to her home. She dragged objects to and fro, hid herself, or sometimes thought that people were out to kill her. And then she would start screaming very loud. From time to time, she was completely delirious, dragging her blankets and sheets to and fro, calling for her husband and daughter, and seeming to have auditory hallucinations. Often, she would continuously scream for hours and hours in a horrible voice. And after a period of 4.5 years of suffering, she died. So that is the original description made by Alois Alzheimer. And that is a classical description of what you call as BPSD, the behavioral and psychological symptoms of dementia. So it is said that earlier, the term behavioral disturbances of dementia was used. And it was later understood and agreed upon that the term BPSD, behavioral and psychological symptoms of dementia, would be more appropriate. BPSD is a very common feature of Alzheimer's disease. It may occur early in the disease. Now we use the term MNCD, major neurocognitive disorder, in the Diagnostic and Statistical Manual, which was published by the American Psychiatric Association. And there have been two interesting terminologies. Number one is MCI, mild cognitive impairment, and another entity called MBI, or mild behavioral impairment. Some research has shown that subtle behavioral problems ranging from mild irritability to a little bit of depressive symptoms can predate the onset of cognitive impairment in persons with dementia. So sometimes these behavioral symptoms can be a part of the prodrome of dementia also. Symptoms may emerge as the disease progresses, and once they are present, the symptoms tend to persist over a long period of time, and multiple types of symptoms occur simultaneously in the same patient. 66% of people with dementia experience behavioral and psychological symptoms at any one point during the course of the illness. And people who are institutionalized for dementia, the rate of BPSD may be as high as 80%. And it is one of the most important factors which increase the caregiver burden. So what are the first manifestations or first symptoms for which a person with cognitive impairment or dementia go to visit a physician? 88% of them come with memory disturbance, but 51% of them complain of change or decline in behavior as the earliest manifestation. There are different behavioral syndromes seen in dementia, but for the sake of convenience, we can classify them into 6 different major categories. The commonest BPSD, as per the Cache County study, is apathy, which was very clearly highlighted by Dr. Matthew Abrahams. What is meant by apathy? Apathy is a feeling of lack of motivation, lack of enjoyment, lack of interest in doing things. So a person with dementia may wake up in the morning and would behave like a school child who is refusing to do anything to prepare to go to school and sit still without any complaint at all. The Cache County study has shown that 27% of people with dementia have got apathy. Second commonest BPSD happens to be depression. And it is a little bit difficult distinguishing between apathy and depression because both are syndromes in which the person appears to be very silent. So how to distinguish depression from apathy? In depression, the person may be crying, the person may be expressing his sadness very obviously, and may also be complaining persistently, consistently that nobody is taking care of him. Nobody is looking after him. Nobody is giving him food. Everyone is torturing him. This attitude of complaining may be persistently present right from morning to evening. That is one of the most important features of depression, which is seen in dementia. But in apathy, you remember, absolutely no complaint. The patient will not be doing anything, will not be complaining at all. The third one, probably the most difficult to manage BPSD, is the executive dysfunction syndrome, more commonly seen in frontotemporal dementia and also the behavioral variant of Alzheimer's. Here we have got disinhibited behavior. The frontal lobe functions may be extremely affected, leading to disinhibition. using obscene words and gestures, singing vulgar and obscene ballads, disrobing in public, running after ladies, showing vulgar gestures. And all these happens at a particular age. A person who was extremely dignified and well-behaved till 70 years of age, once he starts developing dementia, starts to show all these symptoms and becomes a real embarrassment for the caretakers. Cannot take this person out for a public function. If you take him for a marriage, the behavior is unpredictable. You cannot predict whether he would disrobe in public and start dancing and show vulgar gestures to ladies there. So that is executive dysfunction syndrome. Then we have got psychosis in dementia. Psychosis in dementia happens very often towards the late stage of dementia. And we have got delusions which are non-systematized and hallucinations which are simple. So non-systematized delusions means a false, unshakable belief like someone is trying to kill him or rob him of his property, or whether some of his valuables have been stolen by the servant in the home, things like that, nothing very complicated. And auditory hallucinations of some voices talking to you would also be very obvious during this stage, and the person with dementia may reply to these auditory hallucinations. And there are certain terminologies which are attributed to the phenomena of ageism. In central Travancore, especially in Kollam, Trivandrum areas to which I belong to, there used to be this terminology, 60 കഴിഞ്ഞാൽ പിറുപിറുക്കും. We as children used to listen to this kind of phrase right from childhood itself, because if a person starts muttering, it used to be a common norm to think that the time for this person in this universe is almost up. The time for the passport is due. So that used to be the terminology, 60 കഴിഞ്ഞാൽ പിറുപിറുക്കും. Now we understand that this piruvirikal or the so-called muttering is probably a response to the hallucinatory voices which may be present in dementia. And then we have got, in very rare percentage, less than 6% of people with dementia, we have got frank symptoms of mania, overactivity, over-religiosity, excess happiness, grandiosity, and sometimes irritability leading to disruptive behavior and frank violence. We have had a lot of people with dementia who have walked out of the house, and they walk to long distances, reach some unfamiliar place, and they are unable to recollect their name or the place of residence. Finally, some social worker may catch hold of them and they may land up in some institutions for destitute people who are old aged. That used to be the phenomenon, one of the common manifestations of dementia. And finally, the sixth symptom, the sixth BPSD, that happens to be anxiety symptoms. Anxiety symptom is more commonly seen in educated, well-read people who develop dementia. Because a person who has some knowledge about dementia, at least a minimum knowledge that dementia is not curable, it cannot be reversed. If he realizes that he has been diagnosed with dementia, it is just like a scenario in which you are caught in a ship and the contact of the ship with the shore is lost. You see your near and dear ones, your loved ones on the shore, and you're sure that you're never going to meet them in flesh and blood ever again in your life, because the control of the ship is lost and you are receding into the outer sea. So what would you feel at exactly that moment, that point of time? It would be a feeling of panic, a feeling of restlessness, a feeling of intense anxiety. That would be very much manifesting in educated, learned people who have been diagnosed with dementia. Apart from these, quite a lot of other symptoms, including aberrant motor behavior, non-specific irritability, sometimes frank euphoria. All these symptoms may be present, but most of the symptoms of BPSD can be classified under these 6 categories. So apathy, in mild Alzheimer's disease, as much as at 47%, in moderately severe cases up to 67%, and in severe, very severe cases, up to 92% of them may be having apathy. Depression, 12% to 62%, depending upon the severity of dementia. Agitation from 47 to 85%. So we have also got studies which were conducted in Kerala regarding BPSD. One of the studies was conducted in Thrissur itself using the Malayalam version of Behave AD. And that study showed that delusions and paranoid ideations happen to be the commonest behavioral manifestation of dementia, seen in 53% of persons, followed by hallucinations. The study was criticized by many people because apathy, which is supposed to be the commonest BPSD as per many international studies, and also as per the reports of many learned clinicians, was conspicuous by its absence in this study. Apathy was not at all mentioned in that study. Probably, something with the methodology of the study. Among BPSDs, there are certain aspects of BPSDs which are more organic in nature, like wandering, irritability, physical aggression, lack of drive, etc. More functional BPSDs like depression, hallucinations, delusions, etc. And some of them, like sleep disturbance, may be a combination of both also. So what are the factors which can worsen BPSD? There can be factors associated with the pathology of dementia itself, the neurodegeneration associated with dementia. It changes the ability of a person with dementia to interact with others and with the environment. And a disruption in the neurocircuitry can also contribute to BPSD. And this can in turn increase the vulnerability to stressors. Some patient factors like premorbid personality of the person, the psychiatric illnesses which were present earlier, acute medical problems like urinary tract infection, pneumonia, dehydration, constipation, anything which leads to a pain in the patient can manifest as a behavioral disorder. Unmet needs like physical pain, sleep disturbance, fear, boredom, loss of control, everything. And even caregiver factors like caregiver stress, caregiver depression, lack of education of the caregiver regarding dementia, communication issues between the caregiver and the patient, and mismatch of expectations from treatment. Sometimes some people may think that dementia is completely curable, and that expectation itself can be a problem. BPSD can lead to premature institutionalization, diminished quality of life, excess disability, excess financial cost, and great caregiver stress also. So how to manage BPSD? That will be the last part of my presentation. There is this model called DICE model, describe, investigate, create, and evaluate model. So contextualize and characterize the behavior of the patient and determine whether there are immediate concerns for the risk or safety of the patient. Investigate for underlying causes, including infections, including electrolyte imbalance, so many things. Create, that is collaborate between the caregiver, collaboration between the treating team and the caregiver to implement a treatment plan which manages most of the distressing symptoms of the patient. Evaluate when the interventions are ineffective regarding whether something more needs to be done. So regarding the treatment options of BPSD, the first line is definitely the non-pharmacological treatment. Physical activity and mental activity to the extent possible. Enjoyable, meaningful activities to improve the quality of life, including a little bit of walking or any other physical activity which is possible. Something including aromatherapy using lavender or lemon balm. They have been both tested and some marginal improvement have been noticed. Reminiscence therapy, that is a very interesting, wonderful behavioral intervention which can provide some benefits. That is showing a photo album and describing about the people who are there in the album, describing the event during which that photo was taken, or recording, playing a recording of a voice of a family member. And all these things can create a calming effect on, especially in nursing home dwelling people with dementia. Music of any kind, especially soothing music, can generate a positive effect. Music therapy is one area which is being tried and tested for BPSD. One-to-one interaction is very important, especially an empathetic, attentive contact with another person may be a key factor in the psychological intervention. Physical activity definitely increases the level of dopamine. It may be beneficial for improving apathy. It can increase the level of endorphins in the brain, creating a sense of well-being. And of course, it will improve the general health as well. Regarding the pharmacological interventions of BPSD, I'll finish this presentation in 3 minutes flat. So among the various medications available, cognitive enhancers, including cholinesterase inhibitors and NMDA antagonists like memantine have been tried. Combination of both have also been tried, and they provide cognitive benefits marginally and some level of positive effect on the behavioral symptoms. But if the behavioral problems are intense and severe, very aggressive, like severe executive dysfunction, severe psychosis, etc., antipsychotics may be needed. But a problem with antipsychotics is that most of the antipsychotics carry what you call the black box warning, the tendency to produce cerebrovascular accidents and stroke. So atypical antipsychotics like olanzapine and clozapine are the culprits in most cases. Typical antipsychotics carry a much lesser risk. So when we go through the evidence base regarding the efficacy, the risk-benefit ratio, we find that certain drugs like tiapride have got some positive effects, because tiapride is one drug which doesn't produce postural hypotension. Because one of the most important targets of treatment of a person with dementia is to avoid falls at any cost. Because one fall, one fracture of a long bone or a fracture of a rib, and that will start the downhill course of the person. So we have to choose the drug which doesn't produce much of postural hypotension. That is where drugs like tiapride may be useful. Antidepressants may be useful in depression in BPSD, but again, certain things to be careful about. Number one is selective serotonin reuptake inhibitors are the most widely prescribed antidepressants, but they are not the best drugs to be given in elderly because they can produce hyponatremia. So anything which produces hyponatremia or any electrolyte imbalance can be a problem. And again, SSRIs can produce gastritis. Many of these elderly people will be on proton pump inhibitors. So people on proton pump inhibitors for a prolonged period of time, especially in high doses, they can develop hypomagnesemia, and unexplained seizures, unexplained delirium, etc. can be manifestations. Some of these patients may be on sucralfate for a very long period of time, again for the gastrointestinal problems. And prolonged usage of sucralfate in elderly can produce hypophosphatemia. So we have to be careful about all these. So if there is an apathetic mood, drugs like bupropion or modafinil may be useful. They can increase the energy level of the person. If it is a female patient with significant vasomotor symptoms, SNRIs like desvenlafaxine may be better compared to SSRIs. If there is intense gastrointestinal problems, instead of giving proton pump inhibitors or even H2 blockers, an antidepressant with a mild H2 blocking property like mirtazapine may be a preferred drug. So choosing the drugs becomes a very important artistic element in the treatment of BPSD. Anxiolytics, especially in intense anxiety and sleep disturbance, benzodiazepines are best avoided because two categories of drugs which may be best avoided in dementia. Number one is anticholinergics because they can worsen the cognition. Number two is benzodiazepines, especially long-acting benzodiazepines. If you need to give benzodiazepines, give short-acting benzodiazepines like lorazepam for the shortest possible period of time. Z category drugs like solpidem may be better preferred if it is insomnia without much of other problems. So taking into consideration all these problems, we have to choose the best drug. But of course, the drug should be the last resort. The psychosocial interventions should be the most important one. And psychoeducation of the caregivers regarding what is dementia, what is happening to the brain of the person in dementia, and what causes the BPSD symptoms in dementia is a very important part of the treatment. So if the caretakers are able to understand that, that itself can provide a positive impact on the caregiver burden, caregiver stress, and the way in which the caretakers take care of the patient. Thank you very much for your extremely patient listening. Thank you.
Thank you, Dr. Arun. It was a wonderfully precise talk, if I ever heard one. Thank you so very much. I think there's a little time for some questions. There are some questions in the question box, in the chat box. I'll open this to both Matthew and Arun. Is there any evidence for the use of coconut oil in the prevention or treatment of dementia?
Please unmute and talk. Dr. Matthew Abrahams, please unmute and talk.
Matthew, I think you're muted.
Muted. Please unmute and talk, sir.
No.
You have to unmute
Dr. Matthew, you are muted.
One second. Is that okay?
Yeah, now you're okay.
Now you are okay.
There is coconut oil has been lampooned as a culprit for many problems, and then subsequently it has now been accepted more and more as being a health drink or whatever health additive. The evidence for it in terms of Alzheimer's, I don't know whether I'm not very familiar with it, but there is some stories, anecdotal or otherwise, which indicates that virgin coconut oil may actually help improve some of these things or reduce the progression or the chances of dementia. But there is not definite scientific evidence to that extent. Arun, would you be able to enlighten me more on that? Because I think that is about what I know on this.
It's exactly the same thing, sir, what you've told. There have been some anecdotal reports about virgin coconut oil, but I haven't come across any RCTs or any concrete evidence which gives us the confidence to recommend it as an intervention, as a preventive intervention for Alzheimer's.
I think the next question, I'm not quite certain as to how do you manage sleep cycle safely in MND? You mean motor neuron disease, right, Dr. Santosh?
Major neurocognitive disorder, new name for dementia.
Okay.
Yeah, I think I'll try to answer that. So I think Santosh Babu sir has asked one more question regarding the disability certification also. So regarding the sleep cycle issues, reversal of sleep cycle is a very common problem in MNC, especially if the person is institutionalized in an environment in which he doesn't have a chance to get exposure to sunlight. It is always mentioned in the behavioral interventions that a person with dementia, even if it is bedridden, he should be placed at a location in which he can understand the difference between day and night. The windows should be open and a chance to understand the difference. And there should be a clock as well as a calendar on the wall exactly opposite to the place where he is placed so that he can see the time and understand the time. And certain sleep hygiene techniques also have to be educated. And one of the most important sleep hygiene tips for people with MNCD is to avoid any kind of stimulant drinks after 2 p.m., after lunch, preferably. No tea, no coffee, anything like that in the afternoon. Very difficult to practice, but that is one very useful thing. And a little bit of sunlight exposure in the evening and a little bit of physical activity with exposure to sunlight, followed by taking bath in cold water. And any kind of relaxation exercises, including deep breathing or progressive muscle relaxation to the extent possible. I understand that it may not be very easy to teach these kind of things to a person with moderate to severe AD or any other kind of dementia, but to the extent possible, any kind of relaxation exercise at night. And still, despite all these efforts, the issues are continuing. To start with the Z category drugs, zolpidem, that group of drugs, that may be preferred. And that too, the lowest possible dose for the shortest duration of time. And once the sleep cycle is somewhat okay, just tapering and taking of the drug would be preferable. And one thing which we find very common is these people will have vitamin D deficiency. And one of the important aspects of daytime sleepiness happens to be that. That is also addressed along with it. Some of these things could be.
More questions from Dr. Santosh.
I think I answered that disability certification question also, if I am permitted.
Yes, sir.
Can lowering uric acid adversely affect?
No, about disability first.
Disability. Oh, okay, sir. So regarding the disability certification, currently as per the RPWD Act, the Rights of Persons with Disabilities Act, we have got named disabilities, a list of 21 of them. But any new disability can be added, and quite a lot of neurological disabilities have also been mentioned. So I think a combination of neurologists and psychiatrists may be necessary to ascertain the extent of disability correctly, accurately in this case, because we have got people with multiple disabilities coming to us. A person with mental retardation may have visual impairment, hearing impairment, and we have got this formula to calculate that disability in multiple domains. So there should be definitely a neurologist who is the best person to assess the cognition. And a psychiatrist can, of course, assess the behavioral and psychological symptoms. And for assessing the BPSD part, we have got the Indian Disability Evaluation and Assessment Scale, or the IDEAS, which is it is referred to as. That will somewhat help us to assess and quantify the percentage of disability due to the behavioral problems. Regarding the cognitive impairment also, quite a lot of scales are available, and neurologists are the best people to determine that. And after combining these two, that will be the total disability, to the best of my knowledge.
How do you submit?
Yeah, the calculation goes like this: the dominant disability plus 1/3 of the lesser amount. That is, for example, if the neurologist says that the cognitive impairment is 60%, or that is that much of disability is there, and if the psychiatrist gives it as 45%, 60 plus 1/3 of 45, that will be 75%. That will be the total disability.
This means all these applicants will have to go to medical colleges, not to general hospital or headquarters, where neurologists will not be there.
Ideally, I'm talking about the ideal situation, but of course, people like you who belong to the
No, I was facing this problem since last 20 years. That is why I'm asking.
A physical medicine and rehabilitation consultant is supposed to be competent in assessing all kinds.
I was in charge of the disability board for almost 20 years.
Yes. So
okay, sir.
Can I say something?
Yeah, please, Matthew.
Yeah, this is something which was not mentioned. We all talked about major neurological MNDs, their deficits, and that includes all the dementias. But there is an intervening phase which may be intervening, we do not know, which is called a minor cognitive impairment, that is MCI. In the old days, the MCI used to be by definition restricted to a memory deficit alone and nothing else. And if you have an MCI, now what do you define? How do you define an MCI? An MCI is a deficit in memory which enables or does not enable the person to function at the level that he was functioning before, and yet it is not significant enough to affect his activities of daily living. So technically, it would be a situation in between a normal cognitive function and a dementing process. So the implication of that particular diagnosis was the fact that as compared to normal aging, where a person with normal aging would progress into dementia at the rate of about 2% per year, a person with defined MCI would be progressing at the rate of about 10 to 12% per year, which meant that by 5 years, about 50% of these patients in the MCI category would become demented. Now, 2 or 3 things have happened to that. We assume that this may be a prodrome for dementing diseases like Alzheimer, but it is not necessarily true, because when MCI had been followed over a period of time, it was found that it falls into a 1/3, 1/3, 1/3 category, where 1/3 remains more or less the same, 1/3 progresses into dementia, and 1/3 can actually reverse back into almost normal function, which means that probably the group that is reversing may be people who have got pseudo dementia or who've got anxiety and depression, and that is what mimics dementia. Now, MCI has also been broadened in terms of involving other faculties. So you have what is known as non-amnestic MCI, and there you have behavior, there you have other executive function, or you have mixtures of these. The implication of categorizing them in these various groups is the fact that an MCI amnestic is more likely to deteriorate into an Alzheimer's type of disease, or while the other ones may have a behavioral aspect which tends to go into FTD or into DLB or what have you. So broadly, the implications are in terms of, yes, this may be a prodrome of a developing dementia. And yes, this may be the stage at which we can intervene aggressively, both by physical, emotional support and by drugs, hopefully, to be able to slow down the progress into dementia, or even if possible, reverse them. So this is the whole concept of minor cognitive deficits as compared to the major neurocognitive disorders, where all the dementias would be. Just to mention this is only to say that we had not talked about it, and it is worth our while to remember that.
Sir, can I ask you a question, sir?
Yes.
Actually, every one of us seem to be going in for dementia. Is there anything that we can do now that can postpone the process?
Absolutely.
What
It has
can we
been
do,
found
sir?
that actually the incidence of dementia is slowly coming down in the West. The prevalence is high because people are living older, and it is the older patients who are actually still remaining demented. But the incidence is coming down, and therefore it means that we, by some interventions, are able to influence in a positive way the progression into dementia. There are many factors that are probably responsible for contributing to dementia. And there is an overlap between between age, the vascular factors, and the process of dementia. A very small percentage of demented patients inherit genes which make them definitely prone to dementia or increase the chances of dementia. The classic example is the ApoE4 gene with one of the alleles, which makes them more prone to develop dementia, provided other environmental factors contribute too. Well, if you inherit the presenilin gene 1 or 2, then you would find that those are people who would certainly go into dementia, and they would probably develop dementia much earlier than a normal person with Alzheimer's. When you have a blood relative who is got dementia, especially the Alzheimer's, but even more so a frontotemporal dementia, because that is more genetically linked than Alzheimer's disease, the chances of your developing dementia are higher than in a normal population who does not have a blood relative who has got dementia. So as far as age and genes are concerned, these are not as yet reversible. But because of the overlap of the ApoE4 gene, which influences cholesterol metabolism or lipid metabolism, the presence of it accelerates aging and increases the chances of dementia. Likewise, as a corollary, if you treat hypertension, if you treat diabetes, if you treat high cholesterol level, if you improve your lifestyle by stopping smoking, having good exercise, good diet, especially a Mediterranean diet, these are all factors that are supposed to be improving the chances of a good normal aging and reducing the chances of going into dementia. One of the things that has definitely been scientifically proved is that if you improve your cognitive reserve by getting into a field deeper and deeper, or going into multiple fields of interest, so you broaden your entire cognitive reserve, as a result of which the chances of your going into dementia become much less. So therefore, people who know more than one language, bilingual, have been found definitely to have a postponed state of dementia. It is almost by 10 years. Dr. Aladi Swarna has done work on that, original work on that. It has definitely been scientifically proved that knowing more than one language does help our patients. But one of the most important things that we need to do, especially as we grow older, is the fact that social support, in terms of interest, in terms of hobbies, in terms of new things that you want to do learning processes, much more social support in terms of having a friend circle, being interested in art like music or anything. Having a pet has been found to be significantly contributing to the chances of reducing dementia. And the way it probably does it is the fact that it makes the person more sociable, and it also helps him exercise because he takes his pet out for a walk. So a combination of those with the empathy that these pets themselves have got therapeutic value in many, many diseases. So these would probably be the factors which you need to address as we grow older and to reduce the chances of our going into dementia. At the end of the day, the bottom line is have a healthy, happy state of mind and a healthy style of living and be as active physically and mentally as you possibly can throughout your life. Never retire. Those would probably be things that would help you stave off dementia.
Okay, thank you, sir. Thank you.
If we have no further questions and
There are
it's
some
getting
more
late.
questions in that chat box.
Yeah.
Few more questions are there.
The one is regarding lowering uric acid. Can it adversely affect memory? What about statin-induced dementia?
I think the only things I know is the ones I mentioned in terms of high blood pressure, diabetes, high cholesterol, smoking, obesity, lifestyle. The other ones would probably be linked, but I do not know of any study which indicates that there is a definite link between those two. About statin-induced dementia, I'm sorry, I do not know it. Arun, is there anything you know?
Regarding statin-induced dementia, there have been very conflicting reports. I remember when I was an MBBS student, there was this hype that statins prevent dementia. That used to be the norm. And I used to remember some of our teachers used to prescribe statin prophylactically to a lot of people with family history of dementia. Later, some studies came out that it can worsen dementia in a subset of population. Again, just like what was discussed earlier, now no concrete evidence to say that whether it worsens or improves. It's a conflicting territory with conflicting evidence on both counts is what we see.
I think the next question, Dr. Matthew has already answered about the possible measures to prevent dementia. And then there's a question about, is there a need to restrain the patient? In that case, what will be the ideal pharmacological agent for restraining the patient?
I think that's a very difficult question to answer, because for acute aggression, which is threatening the safety of the patient or the caregiver, if the person is not suffering from any Parkinsonian syndromes, or if he is not suffering from anything like Lewy body dementia or Parkinson's dementia, a lowest dose of haloperidol parenteral with Phenergan combination itself can be given to the extent that another option is olanzapine injection is available. Olanzapine fast-acting injection is available. And sometimes if an injection is not feasible, mouth-dissolving formulations of olanzapine, it can also be, or dispersible formulations can be dissolved in water and it can be given. And provided, again, a problem which we have already mentioned is that olanzapine can worsen metabolic issues. So if the person is intractable diabetes or anything like that, it may be best avoided. That point of view, again, haloperidol may be better. Benzodiazepine injections are often given in cases where no other options are available, like Lewy body dementia, where any antipsychotic, even in very low doses, can trigger a worsening. In such situation, giving benzodiazepine injections like lorazepam intramuscular injections can be tried.
I think the next question also has been answered to some extent about examples of therapy. The next question is about, does mirtazapine have a clinically significant H2 antagonism?
Yeah, that I can answer from my experience, really, because theoretically speaking, it has been mentioned. It has got antagonism on H1 and H2, both receptors. H1, it is an anti-histaminergic H1 action that leads to increased appetite and sedative properties. And to a lesser extent, H2 also. So why I strongly believe in this is because I was going through a very significant gastrointestinal problem since last November. I had taken COVID duty and continuously for around 2 weeks I had donned this PPE kit and I was working for 8 hours continuously, trying to do some heroic job without even drinking water. And at the end of 14 days, I understood that I was unable to consume anything at all. And I was subjected to endoscopy. There was, multiple ulcers, right, ranging from esophagus till the stomach. And I was put on multiple PPIs and so many other things, but not resolving. The acid reflux was creating major problems at night. I could not sleep. My weight came down by 15 kilograms. It was probably the most terrible phase of my life till now. Finally, I was trying with various drugs, just like maybe probably Dr. Oliver Amison, a famous professor of cardiology, who was a very significant alcohol addict. He tried a lot of medicines for his addiction, and finally he tried 270 milligrams of baclofen, finally quit his alcoholism, and he wrote a book, The End of My Addiction. And since then, now baclofen extended release is being used as an anti-craving drug. Just like that, just by reading these things, found out this action. I tried mirtazapine on myself, and it produced a remarkable impact to the extent that it disappeared just in 1 week, I should say. And I subjected myself to a re-endoscopy, and there was significant healing of these ulcers. It's not an evidence. You can't take it as evidence-based at all. It is just an anecdotal personal experience. But if you ask me personally, if it has got an action, I would say yes. I tried it on so many patients also with these gastrointestinal symptoms, and they also have reported that kind of benefits. So I guess there is a clinically significant effect.
And one final question. A patient with advanced dementia with Parkinson's disease is having aspiration pneumonia and doesn't allow nasogastric tube. Would you suggest a gastrostomy? I think what they mean is a PEG.
It's a difficult question to answer because being demented, he may pull out the the PEG tube. But at the end of the day, that is probably the only way that you can treat these patients. Because along with dementia and Parkinson's, many of these patients would also have an inspiratory stridor, and they may need even a tracheostomy at that stage. And a tracheostomy to some extent may reduce the chance of an aspiration in that indirect way. But swallowing becomes a problem, and a PEG would eventually be the only way out.
I think we have a
signal is gone.
transmission problem there.
Yeah. You may come back.
I think if we can't resolve that, I think we can end the session. Maybe we can have the question answered later. And I'll hand it back to Dr. Joy for concluding remarks. And
Thank you, Dr. Gilwas. Now I invite Dr. Sharmila PM, our CGP convener, for the vote of thanks. Or to you, Dr. Sharmila.
Hello, sir. Am I audible, sir?
yeah, very clear.
Okay, sir. Today, IMA CGP is very proud to have had a few eminent personalities here with us as we observe World Alzheimer's Day. First of all, I would like to thank Dr. Joy Manjula, our president, Dr. Pavan Madhusudan, our secretary, Dr. Leela Abraham, chairman IMA CGP, for making this meeting possible. And now I would like to thank Dr. Joy MA, President, Thrissur Neurological Society, for the welcome address. Thank you, Dr. Alfred V. Samuels, Vice President, South Zone IMA KSB, for taking the time out for inaugurating this meeting. And thank you to our own Dr. P.C. Gilwas, sir, for the introduction of faculties and being our moderator in this wonderful discussion. We were blessed to have Dr. Matthew Abraham and Dr. Arun B. Nair to enlighten us regarding dementia. And thank you, Dr. Matthew Abraham, sir, for sharing it with us, those painful personal experiences, and giving us an insight to what they go through. and the importance of empathy, and Dr. Arun B. Nair sir for enlightening us regarding the behavioral aspects and treatment of Alzheimer's and related disorders. And thank you to all those who are IMA members, all who are listening in on the Zoom. And it has been a wonderful session. And thank you all. We'll be soon coming up with more such wonderful sessions in the future. Thank you and good night.
Thank you, Dr. Sharmala. Now, the meeting is closed. Thank you all for your participation, especially Dr. Alfred